So in tuberculosis, patients with patients with species other than Mycobacterium tuberculosis are classed as atypical Mycobacterium infection like Mycobacterium bovis or Mrcp. So left untreated, one person with active pulmonary TB may infect 10 to 15 people per year. So that's a lot. And TB is an AIDS-defining disease. Current guidelines say that it may be appropriate to offer HIV testing to patients from an area or background with increased risk of HIV co-infection. BCG should not be administered to an individual with a positive tuberculin test. Can be given up to 3 months following a negative tuberculin test. So after 3 months of negativity, uh, maybe it can be given. Diagnosis of tuberculin tests. Okay, so diagnosis tuberculin tests. Mental test. More accurate and considered standard method of tuberculin testing. Immune-mediated type 4 hypersensitivity reaction. 0.1 ml of 1 to 1000, 1 is to 1000 purified protein derivative injected intradermally. So injected intradermally, and then result is read 2-3 days later. Positive result implies previous exposure, including BCG. So you inject it intradermally, result read 2 to 3 days later. Positive result implies previous exposure, including BCG. So previous exposure is there, whether it can be BCG as well. Result in duration less than 6 millimeter, positive more than 6 millimeter, strongly positive more than 15 millimeters. So in the UK, it's offered to those at risk of TB, health workers, TB contracts, and those 10 to 13 years, to find those needing BCG vaccination. HIV test is used for large-scale screening. Classically involves injection of PPD, the same one, equivalent to 1 lakh units per ml to the skin over the flexor surface of the left forearm. It is then read 3 to 10 days later. So severe induration more than 10 mm without blistering. 5 to 10, just indurated ring, 4 to 6 puncture sites indurated. No induration. Okay, grades 1 and 2 may be the result of previous BCG or avian tuberculosis, while grade 3 and 4 requires a chest X-ray and a follow-up. Interferon gamma assay, based on the principle that T cell of individuals sensitized with TB antigen reduce interferon gamma when they re-encounter Mycobacterium antigen. So increased level of interferon gamma production is presumed to be indicative of TB infection. Assays use antigen specific to M tuberculosis, such as the early secretory antigen target ESAT6 and culture filtrate protein 10. NICE define a dual strategy in the diagnosis of TB as a MANTO test followed by an interferon gamma test if the MANTO test is positive. False negative tests can be due to sarcoidosis, HIV, lymphoma, glandular fever, miliary TB, very young age. And sputum acid-fast bacilli, 3 samples are required. If unable to produce sputum and there is high clinical suspicion, bronchoscopy and lavage. Culture takes 4 to 7 weeks to provide a result, for further 3 weeks to required to identify sensitivity. If clinical and radiological features are consistent with active TB, treatment is generally indicated, even if sputum examination is negative. Biopsy, the diagnosis can be made based on the histological demonstration of caseating granuloma, and chest X-ray will show less than 50% patients show radiological abnormalities. Hyaline nodes of the cone focus may be calcified, and hyaline lymph nodes enlargement may subside as immunity to the tubercle vessels develops. In post-primary TB, the radiological appearance is variable, including patchy solid lesions, cavitating solid lesions, streaky fibrosis, flecks of calcification, solitary tuberculoma, hyaline node enlargement. All this can be there. Treatment according to the 2016 guideline, which is almost the same now. So firstly, treatment initial phase, first 2 months ripe, that is rifampicin, HRZE, classically we used to say rifampicin, isoniazid plus vitamin 6, pyrazinamide and ethambutol. Continuation of the next 4 months, rifampicin and isoniazid plus vitamin B6. Latent TB, so isoniazid alone for 6 months, maybe plus pyridoxine. And meningeal TB, extended continuation phase up to 12 months with the addition of steroids. That's for meningeal TB or spine TB. Directly observed therapy, 3 per week dosing regimen may be indicated in certain groups like Homeless people with active TB, 3 per week, not every day. Patients who are likely to have poor concordance, and all prisoners with active or latent TB. Streptomycin and aminoglycoside used in resistant TB. Fully drug sensitive pulmonary TB patient becomes infectious within 2 weeks of commencing treatment. Asymptomatic patient with history of TB exposure and HIV test positive are recommended for dual therapy for 5 months or INH isoniazid for 6 months. Okay, the anti-TB drug side effects. These are very common side effects. Rifampicin, potent liver enzyme inducer, hepatitis, orange secretion, flu-like symptoms. Isoniazid will be peripheral neuropathy, prevent with pyridoxine vitamin B6. May also cause optic neuritis, but is more common in ethambutol. Hepatitis agranulocytosis, liver enzyme inhibitor as well. Inhibitor. This one is inducer. Pyrazinamide hyperuricemia causing gout and hepatitis, and ethambutol is optic neuritis. And check visual acuity before and after during treatment. Dose needs adjusting in patients with renal impairment. Streptomycin may cause vertigo and vestibular damage, vomiting, cochlear damage, deafness, angioedema or angioneuritic edema, nephrotoxicosis. Another very common bacterial disease, leprosy. It's Hansen's disease. It's a chronic disease caused by Mycobacterium as well, leprae, and Mycobacterium lepromatosis. Acid-fast obligate intercellular bacteria. Okay, leprosy. It's Hansen's disease. It's a chronic disease caused by Mycobacterium leprae and Mycobacterium lepromatosis. Acid-fast obligate intercellular bacteria. Features can be nodular skin lesions, erythematous raised plaques like lesions in arms and legs. So skin lesions are there. Basically, it's a neurocutaneous disease. Skin lesions are there, erythematous raised plaque like lesions in arms and legs. Left undetected leprosy can progressive to cause permanent damage to the skin and nerves, leading to chronic problems with loss of pain sensation, resulting in unnoticed damage to tissues, limbs, and eyes. Management: skin biopsy and needle test in cold area, ear, lobule, and elbow. Paucibacillary leprosy, less than 5 lesion. So paucibacillary less than 5 lesion. Treat with rifampicin and dapsone for 6 months. It's important to know this. Rifampicin and dapsone for 6 months. That is paucibacillary less than 5 lesions. And multibacillary leprosy more than 5. This of course multi more than 5. Remember that. Rifampicin, clofazimine, and dapsone for 12 months. So same, just clofazimine added up, 12 months. Immunology. Immunity in leprosy is T-cell mediated, and tubercular leprosy shows a strong lymphoproliferative response to mitogens and to M. leprae antigens, and would have a preponderance of infiltrating CD4 helper inducer T cells in granulomas, with a few CD8 cells and only an occasional acid-fast bacillus. Lepromatous leprosy, the opposite would occur, with numerous acid-fast bacilli and negligible T cell granulomas. Minority of individuals exposed to M. leprae develop leprosy because of establishing protective immunity. HLA studies have revealed that HLA-DR2 have an association with the development of tuberculoid leprosy. Various other HLA associations are being investigated. Okay, moving towards the viral infections. First thing that comes is infectious mononucleosis, also called the kissing disease, caused by the Epstein-Barr virus, also known as human herpes virus 4, HHV4. It's most common in adolescent and young adults, also known as kissing disease. So there will be features like sore throat, lymphadenopathy, pyrexia, malaise, anorexia, headache, palatal petechia, hepatitis. Splenomegaly may occur in around 50% of the patient and may rarely predispose to splenic rupture. Presence of 50% lymphocytes with at least 10% atypical lymphocytes. Hemolytic anemia can also be there. Okay. Management: rest during early stage, drink plenty of fluid, avoid alcohol. Simple analgesia for any aches or pains. Consensus guidance in the UK is to avoid playing contact sport for 8 weeks, and after having granular fever to reduce the risk of splenic rupture. Okay. EBV associated malignancies like Burkitt's lymphoma, Hodgkin's lymphoma, nasopharyngeal carcinoma, HIV associated central nervous system lymphomas. Non-malignant condition here is leukoplakia is also associated with EBV. So these are all associated with Epstein-Barr virus, which also causes infection mononucleosis. So you see sore throat, lymphadenopathy, fever and headache, petechiae, hepatitis. For measles, it's RNA paramyxovirus spread by droplets infective from prodrome until 5 days after rash starts. Incubation period 10 to 14 days. There will be complex spots in the mucosa, the mouth. Okay. Prodrome, irritable conjunctivitis, fever, complex spots before rash. So this is before rash. White spots, grain of salt on the buccal mucosa, and rash starts behind ears, then to whole body. Ears starting from ears. Discrete maculopapular rash becoming blotchy and confluent. Management will be self-limiting in immunocompetent people. Supportive symptomatic treatment. Measles is a notifiable disease in the UK. Management of contacts. If a child not immunized against measles comes into contact with measles, so if a child not immunized against measles come into contact with measles, then AMR should be offered. Vaccine-induced measles antibody develops more rapidly than that following natural infection. So just give vaccine. This should be given within 72 hours. Okay. Encephalitis. This is live attenuated, by the way. Complications for measles are okay. Encephalitis typically occurs 1 to 2 weeks after the onset of illness. Subacute sclerosing panencephalitis, very rare, may present 5 to 10 years following the illness. Febrile convulsions, pneumonia, tracheitis, keratoconjunctivitis, corneal ulceration, diarrhea, increasing incidence of appendicitis, myocarditis. Okay. Chickenpox is caused by primary infection with varicella zoster virus. Shingles is reactivation of the dormant virus in dorsal root ganglion. Varicella zoster virus is the most common contagious organism. It's highly infectious, spread via the respiratory route, can be caught from someone with shingles. Infectivity 4 days before rash until 5 days after the rash first appeared. Traditionally, patients were thought to be infective until all lesions had scabbed over. Incubation period 11 to 21 days. Okay. Clinical features tend to be more severe in older children. Fever initially. Fever initially itchy, rash starting on the head trunk before spreading. Initially macular, then papular, then vesiculous. MPV. Starts from head, trunk before spreading. Systemic upset is usually very mild. Management is keep cool, trim nails, calamine lotion, school exclusion. Current HPA advises 5 days from start of skin eruption. They also state traditionally children have been excluded until all lesions are crusted. However, transmission has never been reported beyond the 50th of the rash. So small pox used to spread from the head and the limbs towards the center. And this one is like centric. Immunocompromised patients and newborns with peripartum exposure should receive varicella zoster immunoglobulin. If chickenpox develops, then IV acyclovir should be considered. Okay. A common complication is secondary bacterial infection of the lesion. Rare complications include pneumonia. Varicella pneumonia is the most common and serious complication of chickenpox infection in adults. And auscultation of the chest is often unremarkable. You can give IV acyclovir. Encephalitis, cerebellar involvement may be seen, and disseminated hemorrhagic chickenpox. Arthritis, nephritis, pancreatitis may rarely be seen. In pregnancy, occurs in pregnancy in about 3 per 1,000 women in the UK. 90% of women have antibodies to varicella zoster virus, and therefore the fetus is not at risk of chickenpox even though the mother develops shingles during pregnancy. In non-immune pregnant women, it's a potential dangerous disease associated with fetal and maternal morbidity and mortality. Chickenpox exposure in pregnancy, first step is to check antibodies. So first we check the antibodies and check fetal varicella syndrome. Okay. Fetal varicella syndrome and risks of fetal varicella syndrome following maternal exposure is around 1%. It occurs before 20 weeks. If occurs before 20 weeks. Studies have shown a very small number of cases occurring between 20 to 28 weeks gestation and none following 28 weeks. Features of it include skin scarring, eye defects, microphthalmia, limb hypoplasia, microcephaly, and learning disabilities. Management of exposure. If there is any doubt about the mother previously having chickenpox, maternal blood should be checked for varicella antibodies. If the pregnant woman is not immune to varicella, she should be given varicella zoster immunoglobulin as soon as possible. So not immune, you give IgG. RCOG and Green Book guidelines suggest immunoglobulin is effective up to 10 days post exposure. Oral asacol should be given if pregnant woman with chickenpox present within 24 hours of onset of rash. Okay, next is hepatitis A. Epidemiology, high risk group. Epidemiology can be 25% of clinical hepatitis worldwide. Single-stranded RNA picornavirus, usually self-limiting fulminant hepatitis, can occur rarely and does not cause chronic hepatitis. Infection induces lifelong immunity. And high-risk travelers to developing countries, men who have sex with men, drug abusers, coagulopathy, all these are high-risk groups. Management is hepatitis A is a notifiable disease and there is no specific treatment and should be supportive and rest. Hepatotoxin such as alcohol and paracetamol should be avoided. No specific antiviral treatment for hepatitis A can be considered. Prevention is the most appropriate measure against these. Hand washing, food handling, and non-protected sexual intercourse should be avoided until patients become non-infectious. B and C are described and discussed in gastrointestinal section. Okay, next will be hepatitis E. It's a non-enveloped RNA virus spread by fecal oral route. Incubation period is 1 to 2 months and common in Central and Southeast Asia, North and West Africa, and Mexico as well. Causes similar disease to hepatitis A but carries a significant mortality, about 20% during pregnancy. Does not cause chronic disease. The vaccine is currently in development but it's not yet in widespread use. Next is dengue fever, a type of viral hemorrhagic fever, also known as yellow fever, Lassa fever, Ebola. All these are viral hemorrhagic fever. Pleural platelet count plus transaminase levels are typical. High transaminase level, typical of dengue fever. Transmitted by Aedes mosquito. Incubation period of 7 days. A form of disseminated intravascular coagulation known as dengue hemorrhagic fever may develop. 20 to 30% of patients go on to develop dengue shock syndrome. And features: causes headache, often retroorbital, myalgia, pruritic pain, facial flushing, maculopapular rash, pyrexia. Treatment is entirely symptomatic: fluid resuscitation and blood transfusion. H1N1 influenza, swine flu. Outbreak was first observed in Mexico in early 2009. H1N1 virus is a subtype of the influenza A virus, the most common cause of flu in humans. The 2009 pandemic was caused by a new strain of the H1N1 virus. Features can be: majority of symptoms are typical of those seen in flu-like illness, diarrhea and vomiting. So majority of the symptoms are typical of those seen in the flu-like illness, diarrhea and vomiting. A minority of patients may go on to develop an acute respiratory distress syndrome which may require ventilator support. And minority of patients. So high risk groups are patients with chronic illnesses and those on immunosuppressants, pregnant women, children 5 to 15 year old. Okay, for swine flu, the treatment can be two main treatments currently available: oseltamivir, Tamiflu, it's antiviral, and zanamivir. Oral medication or neuraminidase inhibitor, which prevents new viral particles from being released by infected cells. Prevents new virus particles. Neuraminidase inhibitor. Okay, common side effects include nausea, vomiting, diarrhea, and headache. Zanamivir, inhaled medication, ibuprofen, available for equally unwell people. Also neuraminidase inhibitor, NI, may induce bronchospasm in asthmatics. So all these four are swine flu. Okay. Next is COVID-19. It's caused by SARS-CoV-2, newly emergent coronavirus that was first recognized in Wuhan, China, in December 2019. Genetic sequencing of the virus is that it's a beta coronavirus closely linked to SARS virus. Features can be most person experience fever, cough, fatigue, anorexia, dyspnea, and myalgias. Other non-specific symptoms such as sore throat, nasal congestion, headache, diarrhea, nausea, and vomiting have also been reported. Loss of smell or loss of taste preceding the onset of respiratory symptoms have also been reported. Older patients and immunosuppressed patients in particular may present with atypical symptoms such as fatigue, reduced alertness, reduced mobility, diarrhea, loss of appetite, delirium, and absence of fever. Okay, presentation: mild, moderate, severe, critical, and critical as well. So mild can be symptoms as above, no evidence of pneumonia. Moderate symptoms and pneumonia evident clinically or radiographically, SpO2 more than 90% in air. Severe can be clinical signs of pneumonia, fever, cough, dyspnea, increased respiratory rate, one of these plus one of these, respirator more than 30, severe respiratory distress, SpO2 less than 90. Consider CT to exclude pulmonary complications. And onset within 1 week of pneumonia or new or worsening respiratory syndromes, mild ARDS on an IV, moderate severe ARDS on invasive ventilation, variable mortality rate but generally high. And critical septic shock, critical diagnosis of sepsis or septic shock increases mortality risk. Multi-organ dysfunction including cardiogenic shock is also associated with high mortality. Management, WHO May 2020. As you'd expect, this is a novel disease and has a huge number of critical trials are being conducted to establish best management strategy. There is emerging positive data about the use of dexamethasone in hospitalized patients, but this has not been translated yet into guidelines. Vaccine development is under extensive research. Available data suggests not to give the following unless in context of clinical trial: antibiotics unless there is evidence of bacterial infection, chloroquine and hydroxychloroquine, plus minus azithromycin, antivirals including but not limited to ritonavir, remdesivir, mifenovir, favipiravir, immunomodulators including not limited to tocilizumab, interferon beta 1, plasma therapy. Parovirus, DNA virus which causes a variety of clinical presentations. It was identified in the 1890s as the cause of erythema infection. Erythema infectiosum, also known as the fifth disease or slapstick syndrome. Most common presenting illness, systemic symptoms like lethargy, fever, headache, slapstick rash spreading to the proximal arms and extensor surfaces. Other presentations can be asymptomatic, no treatment required. Pancytopenia, aplastic crisis in sickle cell disease. Parovirus B19 suppresses erythropoiesis for about a week, so aplastic anemia is rare unless there is a chronic hemolytic anemia. May require transfusion as part of the management. IVIG proven to be of benefit in immunosuppressant patient. Immunocompetent patient do not usually respond well, but transient remission can be seen. Next is rabies. Rabies caused by the rabies virus of the Lissa virus genus within the family Rhabdoviridae. So what happens is high headache, fever, agitation, hydrophobia, water evoking muscle spasm, hypersalivation. Death is almost always inevitable in patients who develop neurological signs and symptoms due to treatment failure or non-immunization. Only supportive measures are recommended. Management: if an individual is already immunized, then 2 further doses of vaccine should be given. Already immunized, 2 further doses of vaccine should be given. Vaccine is ineffective when administered after the onset of clinical symptoms. Okay. If not previously immunized, then human rabies immunoglobulin should be given along with the full course of vaccination. Not immunized, both. Okay. There is no risk of developing rabies following an animal bite in the UK and the majority of developed countries. So the above management is advised for the countries with the risk of rabies. ORF is generally a condition found in sheep and goats, although it can be transmitted to humans. It's caused by parapox virus. In animals, crabby lesion around the mouth and nose, and in humans generally affects the hands and arms. Initially small raised red-blue papules, later may increase to size 2 to 3 cm and become flat-topped and hemorrhagic. So parasitic infection, firstly it's malaria, the hot topic for Mrcp. So the features can be schizones on a blood film, then there will be parasitemia more than 2%. Hypoglycemia can be a feature, there will be fever and severe anemia, presence of complications can be there. And what are the complications that can be there? It's Since it's a parasitic infection, cerebral malaria, it can reach the brain and can cause seizures, coma, renal failure, uh, can be caused black water fever, secondary to intravascular hemolysis, as we said here, severe anemia due to intravascular hemolysis. So renal failure can be also there. Mechanism is unknown. So it's like basically brain, renal, and lungs. So acute respiratory distress syndrome, hypoglycemia, and DIC. So all these complications can occur. Uncomplicated falciparum malaria. Strains resistant to chloroquine are prevalent in certain areas of Asia and Africa. So in Asia and Africa, you'll find some of these crazy strains which are resistant to chloroquine. So artemisinin-based combination therapies, ACT, is first line for this uncomplicated falciparum malaria. And examples include artemether plus lumefantrine, artesunate plus amodiaquine, artesunate plus mefloquine, artesunate plus sulfadoxine, pyrimethamine, hydroartemisinin plus piperquine. Quinine, doxycycline may be used if ACT is unavailable. Atovaquone, proguanil may be used if ACT is unavailable. So next, moving to the severe falciparum malaria. It's still falciparum, it's severe. A parasite count of more than 2% will usually need parenteral treatment, irrespective of clinical state. So IV artesunate is first line for complicated or severe falciparum malaria. So this is the new one, IV artesunate. Artesunate instead or in combination with quinine in very severe case. So this is the one now. If parasite count is more than 10%, then exchange transfusion should be considered. Shock may indicate coexistent bacterial septicemia. Malaria rarely causes hemodynamic collapse. Tachypnea may indicate ARD as a feared complication of falciparum malaria. So shock may indicate coexistent bacterial septicemia. Important thing to consider. Now non-falciparum malaria. So like not a lot of malarial information is given here. So non-falciparum can be Plasmodium vivax. Most common cause of non-falciparum is Plasmodium vivax, with Plasmodium oval and Plasmodium malaria accounting for the other cases. So vivax, oval, and malaria, but this one is the more common. Plasmodium vivax is often found in Central America and the Indian subcontinent, while Plasmodium oval is for Africa. Vivax and oval have a hypnozoid stage and may therefore relapse following treatment. So this hypnozoid stage therefore can be relapsed following the treatment. Treatment can be non-falciparum malarias are almost always chloroquine sensitive. So this falciparum is the one which is the stupid one. So rest are like chloroquine sensitive. You can give chloroquine. Primaquine should be used in Plasmodium vivax and Plasmodium oval infection to destroy liver hypnozoites. So primaquine will destroy liver hypnozoites. And it's also chloroquine sensitive. Okay, next is schistosomiasis or bilharzia. It's a parasitic flatworm infection. Exposure to contaminated water results in schistosomiasis. Infection is usually acquired through activities such as swimming, bathing, fishing, farming, and washing clothes. So all the water activities will cause this. The following types of schistosomiasis are recognized: intestinal schistosomiasis like S. mansoni for African America and S. japonicum for Asia. Urinary schistosomiasis, S. hematobium for Africa. In addition to the above main three species, which are mansoni, japonicum, and hematobium, locally distributed. The species are S. mekongi in the Mekong River in Cambodia, and Genesis and Introcalatum in West Africa. Schistosoma hematobium, the one in Africa, is causing hematuria. Hematuria and schistosoma hematobium. This usually typically presents as swimmers itch in patients who have recently returned from Africa. Schistosomiasis is a risk factor for squamous cell bladder cancer. Okay. Features can be frequency, hematuria, bladder calcification, single dose of praziquantel. So a bit unique. Okay, so trypanosomiasis is two main forms of this protozoal disease are recognized: African trypanosomiasis and that is sleeping sickness, and American trypanosomiasis, Chagas disease. Two forms of African trypanosomiasis are seen. Both are spread by the tsetse flies. Trypanosoma gambian is in West Africa. Gambia is a West African country. And Trypanosoma rhodesiae in East Africa, Rhinoceros West Africa, tends to follow a more acute course. Trypanosoma chancre, tender subcutaneous nodule at the site of infection. This is a feature of what? The African one, African trypanosomiasis. There will be chancre, tender subcutaneous nodule at the site of infection, enlargement of the posterior cervical lymph nodes, later meningoencephalitis, second stage. And management can be pentamidine or suramine. It can also change in some places with metronidazole. Later disease or CVS involvement, IV Medlar-Support. Okay, American trypanosomiasis or Chagas disease is caused by the protozoa Trypanosoma cruzi. 95% of the patients are asymptomatic in the acute phase. Although a chagoma or an erythematous nodule at the site of infection, there was chancre there and it's nodule here. And periorbital edema is there. Chronic Chagas disease mainly affects heart and GI tract. So myocardium with Chagas and Chagas megaesophagus. Periorbital edema. Complications. Myocarditis may lead to heart failure and arrhythmias leading to cause of death, and GI megaesophagus and megacolon causing dysphagia and constipation. Treatment can be most effective in the acute phase using azole or nitro derivatives such as benzimidazole or nifurtimox, treating complications heart failure. Next topic is leishmaniasis. Leishmaniasis is caused by intracellular protozoal leishmania, usually spread by sandflies and And the organism multiply in monocytes and macrophages. The incubation period may extend up to 10 years. Three forms are seen as following: cutaneous leishmaniasis, mucocutaneous leishmaniasis, and visceral leishmaniasis, also known as Kala-Azar, which is very popular in Asia. Cutaneous leishmaniasis is like this and caused by Leishmania tropica or Leishmania mexicana. Crusted lesion at side of bite caused by sandflies. Maybe underlying, sandfly. Maybe underlying ulcer. Mucocutaneous leishmaniasis is caused by Leishmania brasiliensis. Skin lesion may spread to involve mucus of nose and pharynx. Visceral leishmaniasis, Kala-Azar, mostly caused by Leishmania donovani, occurring in the Mediterranean, Asia, South America, Africa. Fever increase typically twice in 24 hours. Sweats and rigors, massive splenomegaly, hepatomegaly. Pancytopenia, secondary to hypersplenism, and weight loss with or without loss of appetite. Gray skin, Kala-Azar means black sickness or black fever. Management can be pentavalent antimony compound, sodium stibicarbonate, IV daily for 20 to 30 days. For recent disease, pentamidine or liposomal amphotericin may be used. So sodium stibicarbonate is the one, if you remember. So three types of the cutaneous and mucocutaneous in the mouth, nose, and pharynx, and this one is in the skin. This one is like there are some systemic problems like fever, hepatosplenomegaly, hepatomegaly, pancytopenia, sodium stibicarbonate. Nematodes. Ancystoma and Xylostoma brasiliensis, most common cause of cutaneous larva migrans, common in Central and South America. Strongyloid stercoralis acquired percutaneously, walking barefoot. Okay, this is a very common question in the exam. Nematodes, Strongyloid stercoralis acquired percutaneously, walking barefoot. Causes pruritus and larva occurrence. This is similar appearance to larva migrans, but moves to the skin at a far greater rate. Abdominal pain, diarrhea, and pneumonitis may cause gram-negative septicemia. Abdominal pain, diarrhea, pneumonitis can happen. May cause gram-negative septicemia due to carrying a bacteria into the bloodstream. Eosinophilia sometimes seen. Management can be albendazole, and the ivermectin is used particularly in chronic infections. Toxocara canis, commonly occurred by ingesting eggs from soil contaminated by dog feces. Commonest cause of visceral larva migrans. Other features eye granuloma, liver, lung involvement. Tapeworms. It's made up of repeated segment called proglottids. These are often present in feces and are useful diagnostically. Okay. This tapeworm cysticercosis, caused by Tinea solium from pork and Tinea saginata from beef. Management is niclosamide. Maybe there is an upgrade in the treatment. We have to see check on that. Niclosamide. And hydatid disease, caused by the dog tapeworm Echinococcus granulosus. Life cycle involves dogs ingesting hydatid seeds from sheep liver. Often seen in farmers and may cause liver cyst and albendazole as a treatment. So here's the total cycle of what really happens. Eggs or gravid proglottids in feces and passed into the environment. Embryonic eggs or gravid proglottids ingested by normal intermediate host swine. Oncosphere hatch, penetrate intestinal wall and circulator musculature. Oncosphere develop into cysticercosis. Humans acquire intestinal tapeworm infection via consumption of cysticercosis in meat, scolex, adult in small intestine. Embryonic egg ingested by human host. Oncosphere hatch. All this happens. So Tinea solium from pork, Tinea saginata from beef, niclosamide is the treatment. Disease caused by dog tapeworm Echinococcus granulosus. Involves dog ingesting hydatid cyst from sheep liver, seen in farmers. May cause liver cyst, albendazole as treatment. Okay, another important topic before we go to STI and skin. It's basically Toxoplasma gondii. So it's a protozoa. It's an obligate intracellular parasite which infects the body via the GI tract. GI tract or lung or broken skin. It's a parasite. Its oocysts release trophozoites which migrate widely around the body, including the eye and the brain and the muscles. The usual animal reservoir is the cat. So gondii is a cat. Or you can just call your cat Toxo. Toxo is the name of your cat. Although other animals such as rats carry the disease. Okay, most infections are asymptomatic. Symptomatic patients usually have a self-limiting infection, often having clinical features resembling infectious mononucleosis, fever, malaise, and lymphadenopathy. Other less common symptomatic patients usually have a self-limiting infection, often having clinical features resembling infectious mononucleosis like fever, malaise, and lymphadenopathy. Other less common manifestations include meningoencephalitis and myocarditis. So what happens really here? Mild self-limiting non-specific infectious mononucleosis syndrome, disseminated fulminating disease that may damage the brain, the eyes, muscles, and liver and lungs. With age, there is often a focal neurological defect with high input to intracranial pressure, secondary to a space-occupying lesion. Severe manifestations are seen principally in the immunocompromised patients and in fetuses infected transplacentally. Chorioretinitis may be associated with all forms, but it is usually a late sequel of congenital disease. Okay, chorioretinitis may be associated with all forms, but it is usually a late sequel of congenital disease. Investigation antibody test, anti-T, Gondi, IgG, IgM, Sabin-Feldman dye test, more conclusively biopsy of lymph node or other relevant tissues in immunocompromised isolation from CSF, brain or lung biopsy. So in AIDS, you have to remember it's different since it's high intracranial pressure and focal neurological deficit. Congenital toxoplasmosis due to transplacental spread from the mother. It causes a variety of effects to the unborn child, including microcephaly, hydrocephalus, cerebral calcification, chorioretinitis. So, Toxoplasma gondii treatment is usually reserved for those with severe infection or patients who are immunosuppressed. So, we give pyrimethamine, sulfadiazine for 6 weeks. PS for the gondii. So, pyrimethamine, sulfadiazine. Moving to a very important topic, STI and HIV. STI and HIV will have a lot of questions and unbelievably a lot. Too many things. And so the most important topic in infectious disease, maybe.